So this is the outline of my presentation. I'm going to discuss the options, methods of pregnancy termination. Then we discuss in detail on the medical methods. We discuss on the surgical methods. Then we see the diagnosis and management of complications of first trimester pregnancy termination. So in general, methods of termination of pregnancy is divided into two types. One is medical method and the other one is surgical method. So first trimester, it could be managed medically or surgically with manual vacuum aspirations. In the second trimester, medical termination with repeated dose of misoprostol and DNDE are the appropriate technologies for termination of pregnancy. How do we choose the methods? So it depends upon the gestational age, it depends upon the clinical condition of the woman, it depends on the patient's choice, it depends on the skill of the provider and the availability of the methods. So these are the different options of medical methods. So we can use oxytocin, you can use cytotoxic drugs, you can use different types of prostaglandins, or you can use Misoprostol, or you can use solutions like 20% saline and 30% urea. But recently, it is prostaglandins and antiprogesterones which are considered as an appropriate method of termination of pregnancy, because these methods have a very high success rate and have a very low risk of complications. So these are the different options of surgical methods in termination of pregnancy. We have aspiration methods, which could be manual, or it could be electrical vacuum aspiration, or you use sharp methods like TNDC or ENDC, or you can use dilatation and evacuations, or we can insert balloon catheters so that it causes cervical opening, or we can do rupture of the membranes, or we can do hysterotomy or hysterectomy. But of all these methods, it is manual vacuum aspiration and the surgical DNDE, which we do it for second trimester abortions, are considered as an appropriate ways or methods of termination of pregnancy. We no more use surgical curettage like DNDC or ENDC, because these procedures lead to have a very high complications, very high risk of bleeding, very high risk of trauma, and a very high risk of infections. We don't do, or hysterotomy is no more considered as a method of termination of pregnancy. So we use it only in cases of complications. So the only appropriate surgical methods are manual vacuum aspiration in the first trimester and dilatation and evacuation in the second trimester. So this graph or this table shows the list of medical and the list of surgical techniques that can be used for termination of pregnancy. Again, I have said of the medical methods, prostaglandins, especially misoprostol, and antiprogesterone, Misoprostol, are considered as an appropriate methods. On the surgical methods, this is the manual vacuum aspiration and dilatation and evacuation are considered as an appropriate methods of termination of pregnancy. So I will start with the medical method for termination of pregnancy. So we define medical termination as termination of pregnancy using drugs. So the most commonly used M agents are Misoprostol and Misoprostol. So this shows the drugs, Misoprostol and Misoprostol. So you can see these drugs are taken PO. There are different ways of providing these drugs. What is Misoprostol? It is a synthetic antiprogesterone. It's developed as RU486. And this drug, it has an effect which is against progesterone, and it causes or it leads to detachment of the embryo from the uterine wall, and this leads to fetal death. So Misoprostol is given orally in a dose of 200 milligram. So this is the drug, so it is a derivative of progesterone, but this drug has a 5 times affinity to progesterone receptors. And Misoprostol, it causes inhibition of contractility of the myometrium, and it inhibits the secretion of prostaglandin in the endometrium, and it maintains a closed cervix. So this is a function of the progesterone. So Misoprostol, it acts against progesterone, and it causes contractility of the uterus, it causes release of prostaglandins, and finally it leads to fetal days, and it causes cervical opening. So the other drug that we use commonly is Misoprostol. It is a prostaglandin E analog, and originally this drug was meant for treatment of peptic ulcer disease. So we are using the side effect of peptic ulcer disease as for abortion purpose. So it causes uterine contraction, it causes cervical dilatation. Misoprostol is a drug that we use it also for other purposes in gynecology and obstetrics. Like we can use for ripening of the cervix, we can use it for pregnancy termination in the 2nd trimester. We can use it also for prevention and treatment of postpartum hemorrhage. So Misoprostol can be given in different routes. So you can give it orally, you can give it vaginally, you can give it buccal, or you can give it sublingually. This picture, it shows the mechanism of both drugs, the mechanism of Misoprostol and Misoprostol. So Misoprostol, it causes fetal death, it causes by causing residual necrosis and blocking prostaglandin receptors. And Misoprostol, it leads to cervical ripening and opening of the cervix, and both drugs leads to detachment and expulsion of the fetus. What are the indications for using medical abortion drugs? So we can use it in the first try for a woman whose pregnancy date is less than 9 weeks of pregnancy. But it doesn't mean that we cannot use beyond 9 weeks, but surgical method is more effective, like beyond 9 to 12 weeks. So that's why we do MVA if the gestational age is between 9 to 12 weeks. So what are the contraindications for using medical abortion? So if you have an allergy to Misoprostol and Misoprostol, it's contraindicated. In case of hemorrhagic disorders and women with concurrent anticoagulant therapy, and in cases of suspected or confirmed ectopic pregnancy, because Misoprostol and Misoprostol act on the uterus, so it has no effect on extrauterine pregnancies. Rather, it can delay the diagnosis of an ectopic pregnancy. So always, if we are not sure of an ectopic pregnancy, it's better to delay and confirm or rule out an ectopic pregnancy. So in case of inherited porphyria, again, it's contraindicated. So in this clinical condition, one has to be cautious. So if a woman has an intrauterine device, I think it's better to remove first the device, and then you can start the medical abortions. In clinically unstable women, like we prefer surgical abortions in hemodynamically unstable women. In case of severe anemias, if there is a poorly controlled asthma, in case of chronic adrenal failures, we have to be cautious in using medical abortions. So these are the special conditions that you need again to see. In case of an asthma, STIs, like if there is an acute infection, it's better to treat the infections. In case of HIV, because also these drugs also pass through the breast milk, so it's good that we give special attention in those women with breastfeeding. Usually, it is recommended to discard those milk within 4 hours of use of Misoprostol in obese and multiple pregnancies. So what is the regimen? So in general, instead of using Miso alone regimens, the success rate is very high in case of use of combination regimens. So what we recommend is, we recommend on first day to use Misoprostol 200 milligram PO. Then we can give Misoprostol, which can be given oral, buccal, or sublingually, like 24 to 36 hours after Misoprostol. So this is the recommendation on the Ethiopian guideline. So if the gestational age is less than 7 weeks, so you can give Misoprostol PO on day 1, and on the 3rd day you can give Misoprostol 400 micrograms. This is 2 tablets, and you can give it orally. This is for those with gestational age less than 7 weeks. But for those women with gestational age of 9 weeks, it's recommended to use Misoprostol orally, or you can use on day 3 4 tablets, that is 800 microgram vaginally. So in our setup, usually it is recommended to give vaginal dose of Misoprostol. This is what is written on the technical and procedural guideline of Ethiopia. So between 9 to 12 weeks, you can use medical abortions, but we use it in an area where there is no an option of surgical abortions, because the risk of failure is very high. So you can use a single dose of Misoprostol and repeated dose of Misoprostol. So it is also recommended in the 2nd trimester pregnancy termination. It's highly effective. So you can give Misoprostol on day 1, and you can give Misoprostol on day 3, with or without a loading dose. So this is the recommended dose and regimen in 2nd trimester pregnancy between gestational age of 13 to 24 weeks, and it is equally effective like surgical DND. So Misoprostol single dose can be used for case of an missed abortion. We used to provide only surgical abortion in case of an incomplete abortion, but now evidences have showed Misoprostol alone can be used for case of PAC, like missed abortion or incomplete abortion. So you can give 800 microgram Misoprostol vaginally, that's 4 tablets, and it has a success rate which goes up to 90%. So we can use it also for an incomplete abortion less than 12 weeks. So you can use 600 microgram orally, or you can use 400 microgram sublingually. So it is effective like manual vacuum aspiration. What is effectiveness? So with a combination regimen, it is effective like 90%. The chance of success is very high. If you use Misoprostol alone, the effectiveness is slightly lower than the combination regimen, that is 90%. So what are the side effects of medical abortion? So when we say side effect, these are clinical condition which doesn't need a medical attention. Usually, proper counseling will improve these conditions. So definitely it causes pain, it causes bleeding, it causes fever, nausea, vomiting, diarrhea. So these are the side effects. Usually it can be managed by reassurance, or you can give antipyretics, or you can give some analgesic drugs. So these are the complications. When we say complications, these are clinical conditions which need medical attention. So with medical abortion, you may end up with heavy bleeding, or there could be an ongoing pregnancy. We know that medical abortion is not 100% effective. So it's possible that the pregnancy can continue. Or it may end up with an incomplete abortion leading to an infection, or it can cause an infection. So heavy bleeding. So this leads to a vital sign derangement, or women may be hypotensive. Okay, so this clinical condition has to be managed by this way. Okay, you need to do immediately medical abortion. You have to do manual vacuum aspirations. There are very few cases of medical abortion in the first trimester pregnancy termination which needed transfusion, but there is no report of surgery or doing hysterectomy or hysterectomy for medical abortion in the first trimester pregnancy. So infection with medical abortion is extremely rare. Okay, so even it's not indicated to use prophylactic antibiotics with medical abortion. But this can be treated with broad spectrum antibiotics, or if there are remaining parts of a fetus, so one can consider doing manual vacuum aspiration. Incomplete abortion. So it occurs in 2 to 5% of medical abortion, and usually women will have a continuous vaginal bleeding like spotting, and you see subinvolution of the uterus and the cervix remains open. So one can do an ultrasound or to confirm this tissue, and it's definitely treated with manual vacuum aspiration. One of the complications of medical abortion is ongoing pregnancy, or we call it a failed medical abortion. So it occurs with an incidence of 1 to 2% of the cases, and one has to suspect a failed medical abortion if a woman has no bleeding after taking medical abortion. One has to suspect an ongoing pregnancy. So on clinical examination, usually they have little or no spotting after medical abortion, and still the pregnancy symptoms is going, and definitely you'll have an enlarged uterus. So this can be confirmed by doing an ultrasound. So there are two options in the management of failed medical abortion. One can continue with medical abortion, or one can go with a surgical abortion, that is, you do manual vacuum aspiration. So this is again what I would like to stress. So in case of suspected or diagnostic ectopic pregnancy, we should not use medical abortions. So if we suspect, we have to refer to the place where these women are handled with the best care and operative facilities. So the other ways of termination of pregnancy is surgical methods. And the commonest surgical procedure that we do for termination of pregnancy in the first trimester is manual vacuum aspiration. So manual vacuum aspiration is evacuation of the content of the uterus using flexible cannulas and syringes. So it has three parts. It has an MVA cylinder, it has a valve, and it has also a cannula. So this picture shows a complete MVA set. So the tip is a cannula, and it has a valve, and it has also a syringe. It's called the iPass MVA Plus with an iPass Easy Grip cannulas. There are different types of cannulas, and these ones are the ones which are a little bit rigid, the rigid cannulas. So these are the different parts of the cannulas. So the parts of an MVA set. So it has a cannula, and when you see the cannula, it has a plastic part with an aperture at the tip, which is used to remove the content of the uterus, and it has also dots, which helps us in determining the length of the uterine cavity, and it has also a wing and a base. And cannulas are meant to evacuate the content of the uterus, but we can use the small sized cannulas to dilate the cervix. So we can start with 4 millimeter cannulas, and this helps us to open the cervix. So the syringe has a plunger handle, it has a collar stop, it has a cylinder, valve, and valve buttons. So when you see the cylinder, it has O-ring. The purpose of the O-ring is for lubrication. So it decreases the friction between the plunger and the cylinder. And we use also silicone as lubricant. So it has a collar stop, it has a plunger, and it has also a barrel. So which cannulas to use? It depends upon the gestational age and the cervical dilatation. For lower gestational age, we use like number 4, 5, 6 cannulas, and for bigger gestational age, we use the larger size cannulas. So this shows the gestational age in weeks and appropriate size cannulas. Like for a uterine size of 4 to 6 weeks, we can use number 4, number 5, number 6, number 7 millimeter cannulas. So what are the indications? Manual vacuum aspirations, it has therapeutic as well as it has a diagnostic. We can use it for diagnostic purpose. We use it for menstrual regulation, we use it for an abortion the first try, and we use it also for diagnostic procedure. So we use it for infertility, okay. So we can do endometrial dating with infertility, and we can use in a woman who has abnormal uterine bleeding. We can take sample from the endometrial cavities. So this shows that MVA has also a diagnostic as well as therapeutic purpose. So these are the steps when we do an MVA procedure. So we have to prepare all the proper instruments that we need for the procedure. We have to prepare the woman, use the lithotomy position. We have to clean the cervix with antiseptic preparation. There may be a need to dilate the cervix, so we can do it with a small number cannulas, or we can use a single dose of misoprostol, and we can evaluate after 4 hours. So insert a cannula, suction the uterine contents, inspect the tissue, and if there are any additional needs, we do also a procedure. Then we go for processing instruments. So of all these steps, we have to remember examining fetal tissue is very important. When we can confirm that there was a pregnancy, like you do MVA, and if there is no tissue, this could be an ectopic pregnancy. And inspecting the tissue also helps us to know indirectly the gestational age. Like there is an amount of tissue that we expect at gestational age of 12 weeks and at gestational age of 6 weeks. So this helps us to rule out incomplete evacuation. So examining product of conceptus tissues, this is usually the most neglected, but this is also the most important step when we do manual vacuum aspiration. So with this procedure, we can ensure that the pregnancy was inside the uterus, and also it gives the provider pre-procedure evaluation. Indirectly, you can know with the amount of the conceptus tissue, you can compare it with the gestational age. And it also helps provider to plan for a follow-up. Like if there are remaining tissues, we can even send the specimen for histopathology. So what are the signs of complete evacuation when we do manual vacuum aspiration? So you see red or pink foam, okay, when we do tissue examination within the cannula, and you hear a gritty sound, and usually the uterus also contracts, and the cervix again contracts around the cannula. So MVA is a very safe surgical procedure in first trimester pregnancy. If a provider is skilled enough, usually complications is extremely rare, especially when we compare it with the surgical method. So manual vacuum aspiration is very safe. But rarely you may end up with some vagal reactions, or there could be an incomplete evacuation which leads to infection, or very rarely again you may have a uterine perforation if you don't do it gently, or there could be an accumulation of blood within the uterine cavity leading to hematometra. So this picture shows an electrical vacuum aspiration, which has the same function as the manual vacuum aspiration, but with this instrument, so we use electric source to create the vacuum. So these are the old methods, which we call it DNC and ENDC, and we used to do these procedures, but these curettes are dangerous, causing an immediate and late complications. So, studies have shown that MVA is better than ENDC and DNDC because there is complications very low. You can finish the procedure very fast. In case of MVA, pain and bleeding is less, and you need less skill, or like the need that the duration that you need to train somebody with MVA is very low compared to ENDC and DNC. So again, I say that we recommend doing manual vacuum aspiration than ENDC or ENDC. So the only indication to do ENDC and DNC is in a place where there is no manual vacuum aspiration. So this is a curate, and this was the one. These are an absolute procedure. I just want to show you the way we do these procedures. So only one slide. One surgical method which is recommended is DND, and we do it in the second trimester. We call it dilatation and evacuation. It is a surgical method of an abortion using a combination of cervical dilatation and suction aspiration and removing the content using a specialized forceps. So it's a very effective method of termination of pregnancy in the second try, but it needs a skilled, trained provider. So in summary, I would like to tell you that these are the appropriate technologies which are recommended by World Health Organization, and you can see the 2012 editions. So the appropriate technologies in termination of pregnancy in the first trimester is you can use a surgical option, manual vacuum aspiration, or a medical abortion, or in the second trimester you can use dilatation and evacuation and medical abortion with repeated dose of misoprostol. So complications of an abortion. So complication can occur with the method. So I have discussed complications with each methods, like with MVA and with medical abortion, or these complications, it can be an early complications, like you can have perforations, you can have sepsis, or there are delayed complications which can lead to infertility, recurrent abortion, or chronic pelvic pain. So these are my references. So I used all the standard textbooks, and I have used additionally literatures on safe abortion. So this is the end of my lecture on abortion. So it had two parts, introduction part, and this one is on method of termination of pregnancy. And thank you very much.